Hi, I'm Virginia, one of the PhD fellows, and as well as said, I'm here to give you an update on carbon modeling. So before we start, I'll talk to you about the cheetah trial, which is really the trial around which the carbon model was built and developed. Next slide, please. Okay, so the cheetah trial was a trial that was completed in 2022 and looked at introducing a simple intervention in operating theaters, so a change of gloves and instruments for the staff before abdominal wound closure, and seeing whether this would reduce SSI, so surgical site infection rate, compared to routine practice. So the trial was very successful. It recruited over 13,000 patients across 7 low-middle-income countries, and it actually did show that introducing a change of gloves and instruments before closing the abdominal wound does lead to a reduction of 13% in surgical site infection when compared to routine practice. So we know from this trial that this intervention is clinically beneficial. A cost-effectiveness analysis was then completed that showed that the trial intervention is also cost-efficient compared to the routine practice. So we have outcomes with regards to clinical and costs. However, you can tell me, well, yes, but you're using more gloves, you're using more instruments per each case, so surely the carbon footprint of the operation will go up as a result. And this is really what we wanted to find out with this model. So really, the cheetah carbon model aimed to understand whether the cheetah intervention was associated with an overall decrease in wound-specific carbon footprint. So the wound-specific carbon footprint was calculated for the intervention group as the carbon footprint of the trial intervention, so the carbon footprint of the use of the gloves and instruments, plus the carbon footprint of the SSIs times the rate of SSIs. This was for the intervention group. Of course, for the control group, the intervention was not used, so the wound-specific carbon footprint was really the carbon footprint of the SSI times the rate of SSIs. So the carbon footprint of the SSI is really in this carbon model, is really the most detailed and up-to-date estimation of a carbon footprint for SSIs that there is in the literature. And also it's been done for high and low middle-income countries separately. We also calculated the carbon footprint for different types of procedures, so for clean contaminated and then for contaminated and dirty. And what I'm going to show you today is some of the results that are about the clean contaminated procedures. So as you can see here, the intervention carbon footprint, both in high income and low middle income countries, is less than in the control group. Meaning that, yes, we're using more resources, however, we're preventing so many SSIs, then as a result, we're still leading to carbon savings per procedure per patient. So we're looking at 4.2 kilograms of CO2 equivalents saved in high-income countries, and 10.9 kilograms CO2 equivalent saved in lower middle-income countries per patient. So the 10.9 is equivalent as the emissions that you would have if you were to drive from here to Leicester. And this is per patient, so it is significant. So now there has been some time from when the trial is completed, and we have reached clinical outcomes, cost outcomes, and carbon outcomes. So we can say that we have comprehensively assessed whether the trial intervention can be introduced in clinical practice. And having this triad of outcomes for the trial intervention might actually mean that we are able to bridge that gap between generating the evidence and bringing it into clinical practice. So we're trying to do a similar thing for our next trial that is also recruiting, the Dragon trial. And we'll hear a bit about this in the next sessions. But for the Dragon trial, which is looking at reusable and disposable drapes and gowns, we're looking to achieve this clinical, cost, and carbon outcomes all within that primary result paper, thus eliminating that delay that has been between finding the clinical outcomes, the cost, and the carbon. We're finding them all at the same time. So hopefully that means that we can further speed up that we can further reduce that gap from generating evidence to introducing the intervention into clinical practice. And this should hopefully apply to other types of PPEs as well. So that's me, and I'm looking forward to the discussion. Thank you.
Wow. Wow, Virginia, that's fantastic. For those of us practicing in low, middle-income countries, there are times that the cost outcome outweighs every other consideration. But to start discovering that there are interventions that not only satisfy cost, but also looks at the carbon model as well as the clinical outcome in patients is fantastic. But the first question that went through my mind looking at your slides is, what went into the calculation for SSI that made that significant impact? Because if you were here at the breakout session and Sivesh and James were talking about it, the practitioners in low middle income countries think so much about the cost of changing gloves that many of them would rather not have it. But weighing it against SSI produced this very significant outcome. So what went into SSI calculations?
So thank you for that question. So if you were here last year, then you might have been involved in finding that result, actually, because we had different kind of consultation with experts to decide what resources should be included in calculating an SSI. So for us, we established some system boundaries, so we decide what to take into account, and that should have been within the hospital confines. So this is really the place, the resources that we were looking at within the hospital. And then through these consultations, we realized what resources we should take into account. They are the wound swabs, wound dressings, the length of stay, the antibiotics given, and the rate of readmission, reattendance to A&E, and reoperation, all for the management of SSI. So this is what went into the carbon footprint of the SSI.
Yeah, that's fantastic. I saw Mwai in the sitting up there. We also did a study, and you discovered that a patient coming back for wound dressing in some low middle income countries spends so much on transportation just to come, and of course a lot more carbon. I'm not sure that was factored into this, but just to say that there's still a lot more that goes into surgical site infection, particularly in low middle income countries. You want to say something to Virginia?
Yeah. Are we moving on to?
Oh, yeah. So just a comment on that. So I would say that we can we can expand whatever we want to include in the model, and it could include anything and everything. And at some point, we just need to set a boundary. So we need to decide where we need to stop counting. And this is because we want to develop models that are pragmatic, that can be developed, and we can estimate carbon footprint with in a pragmatic, faster way, so that we reach those outcomes faster, and again, aiming to bridge that gap between generating the evidence and clinical practice.
There's a question here, even though our time is running so quickly. Now, do you see, I can see that the Dragon study being proposed is already taking all this into consideration. Do you see that becoming a norm? Do you see us getting to a point where all these three outcomes can be factored into the protocol in planning for a research?
I certainly think that's the future, because I think we live in a world where we can't really do something without thinking about the costs, the resources that go in it, and the carbon output, because we know that the clock is ticking and we need to do something, and we know the surgery is so energy and resource intensive that we definitely need to be careful about what we do. And of course, clinical safety is paramount, but cost and carbon are, they're the future. The triad of outcomes is the future.
Excellent.
Rob?
Excellent.
I would say carbon models are critical to understanding the environmental impact of any operation, any care pathway. But as we've already explored, they don't exist in their own vacuum. They have to be alongside both a financial model and they have to be alongside behavioral change. And if we can't put all three of those together, then we're never going to make the progress to actually reducing the carbon burden and reaching our environmental goals. And I think we've already demonstrated that in the first session, in that none of these things exist in isolation.
Yeah, definitely. I can only agree with that. Well,
Thank you very much. All of us will be available, and Virginia in particular, if you have questions, particularly regarding the Dragon trial that's been planned. Now that Anil is on the stage, I think
we need
it's
to
time
go.
for us to go.
thank you very
everyone.
much. Thank you.
Thank you.